So thank you for that introduction, Lara. So I'm going to talk about Ehlers-Danlos syndrome in particularly context with trauma and PTSD. And this is not to say that people with Ehlers-Danlos syndrome, there's a greater prevalence of trauma and PTSD health conditions, but it's trauma with Ehlers-Danlos. Probably through the first set of slides quickly so I can get to the biological basis of trauma, which is actually quite interesting. So I'm going to talk about trauma, what is types of trauma. I'm going to talk a little bit about PTSD in more detail, and then I'm going to talk about a study that starts to make the link between trauma and long-term health conditions. Then I'm going to talk about trauma in the brain, how that works, and then introduce you to a couple of therapies that we use to resolve trauma, and I'll give you a couple of case studies at the end. Trauma. Okay, so trauma starts with an event that invites high emotional distress, and it tends to be the big 7 emotions of terror, horror, fear, disgust, shame, humiliation, and embarrassment. Okay. When we experience those sorts of emotions, it lends itself to that event becoming traumatic. And I'll explain the biological basis of that a little bit later. Okay, so quite often if you're talking to a trauma therapist, they'll talk about trauma in terms of 2 types, and they'll start to say big T trauma and little t trauma. Okay, so big tends to have what we call the UDIN characteristics. So the UDIN's an acronym for unexpected. So this event happened out of the blue and it was sudden. It was unexpected. D is dramatic. I is isolating, so even if there were other people around, we felt alone in that moment. And N, which is probably the most important thing, is that we had no strategy for coping with it. It was so overwhelming, we did not know what to do. And it's interesting, when we're in situations in which we feel we cannot cope, that will invite anxiety straight away. Yeah. As soon as you have a situation in which you feel that you can cope, your anxiety, your fight-flight system, your stress system is not necessarily brought online. Okay. Okay, so what type of events lend itself to what we call big T trauma? So these are a range of experiences, and they could be natural disasters, such as a tsunami, man-made disasters, such as the London bombings. Accidents, such as a fall, road traffic accident, train crash, medical matters, a physical assault, a robbery, murder, a sexual assault, war, ethnic cleansing, torture. These are big events. Okay, so little t trauma. So even though it's called little t traumas can almost have a significant effect as big T traumas. So these events are not necessarily particularly life-threatening. However, they do tend to devalue the sense of self. Okay. So if there is a threat to our physical self or our perceived sense of self, this can result in experiencing a traumatic reaction. And these are events we tend to feel that we can't cope, or we feel a little bit helpless. So this might be something like, when I was 7, a teacher shouted at me and I felt that I was not good enough, okay? And then we might see later on that somebody develops low self-esteem. Now, low self-esteem is not something that we're born with, it's something that happens. And it tends to happen because of a series of experiences that we had in which we felt that we're not good enough. And so we know that the little t traumas can exert their effect in our present day lives, even if those little t traumas happened a long time ago. And the critical age is probably around 6, 7, 8 when our identity is forming. And if we experience some of those little t traumas then, we develop a belief about ourselves, which we call a core belief, which just carries with us into the future. Okay. Okay, so some events that can lend itself to little t traumas are infidelity, being shouted at, school bullying, a relationship ending, leaving a job, divorce, legal issues. So you can see how leaving a job, we might start to develop the belief that, we're not good enough. And if we're not good enough, how's it affecting us today? Well, we might find ourselves in a job that actually is way beneath our skill set. Why? Because opportunities are coming up, but we're too scared to go for those opportunities because we feel that we will fail. We feel there will be a repetition to what happened before. So we can see that the little t traumas, we may not necessarily be having flashbacks, but they can still exert their effect in our present lives. Okay, so what is PTSD? So I suppose PTSD is a specific type of big T trauma. And I'm just going to whiz through some of the key definitions. So what you would have to see to be diagnosed with PTSD. Okay, so this is based on the DSM-5, which is the Diagnostical Statistical Manual of Mental Disorders, which was developed in the US. And broadly, we'll look at the individual criteria in a second, but broadly, you've got three sets of symptoms. You've got the re-experiencing, which we'll look at in a second, and the re-experiencing tend to be intrusive thoughts. We have avoidance, so avoidance of anything that reminds us of the trauma, and then we have a heightened arousal response, and these are things like irritability or anger. So let's look at those in a little bit more detail. Okay, so for a diagnosis of PTSD, you'll see certain criteria, criteria A through to E. And if you meet these criteria, that's when you will receive a diagnosis of PTSD. So criterion A is exposure to death. So it's an event in which you felt that your life was threatened, or there was possible, actual, or potential serious injury or sexual violence. Okay? Now, this could be the direct exposure. It could be that you witnessed something happen to somebody else, or it could be that you just heard somebody close to you experiencing such a traumatic event, or it could be that you just arrived, like as a first responder, you just arrived at a big event and you just saw the aftermath, just what happened. So any of those criteria can be the first criteria that lends itself to a diagnosis of PTSD. So criterion B is intrusive symptoms, so the re-experiencing. So this tends to be really what we know about this will help us differentiate big trauma and PTSD, which is the re-experiencing. It's the key feature. And this can be nightmares or flashbacks. And these can be kind of like the people who say, I've got 50 flashbacks a day, or it could be people who say, I'm experiencing flashbacks, around about 3 times a month. But if you're experiencing flashbacks and nightmares, we're tend to thinking that there's PTSD just around the corner. And so they could also be unwanted, upsetting memories, and just general emotional distress. So criterion C is avoidance. So let's say I was physically assaulted on the way to the bakery, and since that time I do go to the bakery, but I don't go down that same road in which I was assaulted. Okay, that's avoidance. We're avoidance because what's happening when I go down that road is that I suddenly get a reminder of what happened, and I get all the feelings coming back. And then just some of the other criteria. So we've got criterion D, which is a negative alteration in mood. So this would be feeling more anxious or feeling more depressed. Criterion E is difficulty sleeping, and also you see a lot of people saying that, I feel more jumpy since that happened, I feel startled, I'm irritable, I'm really angry, I'm snapping at all my friends and relatives. That's telling us that that's the heightened level of arousal. And what you've done is just elevate that stress response. And then criterion F is the duration. So you have to have symptoms for at least a month. Now, in a sense, the worst thing that you can do, if somebody experiences one of those qualifying events that might lend itself to PTSD, the worst thing we can do as therapists is go straight in and try and give some trauma counselling. And that's because you can actually invite PTSD by doing that. For a lot of people, the event will resolve itself naturally if you don't interfere. So that's why you've got symptoms have to last at least a month. Okay, so who gets PTSD? So roughly about 7 to 8% of the population will experience PTSD at some point in their lives. So of the people who do experiencing a qualifying traumatic event, the average is about 20% will develop PTSD. And the number varies on whether it was an attack, such as war, or some sort of natural disaster. But one of the risk factors that can increase the likelihood of somebody experiencing PTSD is actually a traumatic childhood event. And I'm going to talk a little bit more about that now. Okay, so there was a study done in the 90s. It's called the ACEs. So the ACEs stands for Adverse Childhood Experiences Study. It's a really interesting study. So in the 90s, there were some health organizations. They were really interested in the link between experiencing a traumatic event as a child and having a future long-term health condition. So this is quite a large study. They had 17,500 people involved, and it was a really simple survey. And people just had to tick if they'd experienced a particular type of childhood experience in their childhood. And these included physical, emotional, or sexual abuse, tick. Physical or emotional neglect, if you'd experienced one of those, you would just tick it. Having a parent with a mental illness, having a parent, one or both parents, with some sort of substance or alcohol dependence, having a parent who was in prison or jail, experiencing a parent's separation or divorce, or being involved in or witnessing domestic violence. Okay, so those were, we know there are a lot more experiences that could lend itself to trauma, but for this study, these were the adverse childhood experiences that were involved. So basically, the participants were giving a list, and if they'd experienced those events as a child, they would just tick. And for every tick, they were giving a point. And your points would be your ACE score. So what did they find? So they found that an adverse childhood experience was common. 67% had at least one adverse childhood experience. 12% had 4 or more adverse childhood experiences. And then there was a massive correlation between the number of adverse childhood experiences that you had and a long-term health condition. So for people who had 4 or more adverse childhood experiences, there was a between 2.5% and 12% increased likelihood of having COPD in the future, hepatitis, depression. So there was a 12% increased risk of experiencing having some sort of suicidality. We heard about suicidality this morning. But there's also an increased risk of having liver and digestive issues, lung cancer, and ischemic heart disease. So how can we explain this? Well, I suppose some of the researchers were thinking, well, maybe it's just because if you had that many traumatic experiences as a child, maybe it was a bit of a crappy life, you got in with the wrong crowd, you started smoking, you were eating unhealthily. But that wasn't enough to explain the correlation between the long-term health conditions. So when they looked into it, they noticed that actually these adverse childhood experiences had a profound effect on the developing brain. The childhood brain was very, very sensitive. And we saw in MRI scans that there were differences in the amygdala. I'm going to talk about the amygdala a little bit later on. But there were differences in the brain structure of the people who'd experienced an adverse childhood experience. We know that if you experienced one of these events as a childhood, we heard from Dr. Maitland and Dr. Crowell yesterday, it turned up the volume level. Yeah? So you were much more sensitive to future stresses. And it also dampened down the immune response, making you more susceptible to viruses, to diseases, to all sorts of illnesses. Okay. So, we've seen the elephant before. Dr. Maitland showed you a slide with the elephant. Is trauma one of those invisible elephants in the room that we sometimes ignore? Okay. Okay, what do we need to do? Why is this car running so slowly? We have to take the elephant out. Let's address the elephant. Unfortunately, we've got the techniques to do this. We can clear trauma, and I'll give you a couple of case studies a bit later on. Okay, so recovery from trauma and PTSD. Just because of time, I'm gonna move on. So we know that the National Institute of Mental Health, we might think, let's go to the doctor, let's get a pill. But actually, pill is the second line treatment. The first line of treatment is a trauma therapy. And there are some really effective trauma therapies out there, and I'm going to talk about them now. But first of all, I just want to talk about trauma and the brain, just so you know what's happening in the brain. So there's lots of different explanations about trauma in the brain, and this is just one of them, and this really works quite well for my clients. Okay, so we know that the brain is very complicated, but we're going to simplify things by just making two divisions. We have the thinking brain, okay, the prefrontal cortex, and we have the feeling brain. That's it, thinking and feeling. So we know that thinking brain is rational, it's logical, and we know the thinking brain understands context. Now, when I say context, I mean time. The thinking part of your brain will understand the difference between past, present, and future. And the reason why this is important is because the feeling part doesn't understand time at all. It doesn't get into it. It's not interested in time. So anything that the feeling part of the brain is exposed to is happening now. Yeah, the feeling part of the brain will just follow your attention. Okay, and the other part, the thinking part of the brain will understand nuances between imaginary and real. The feeling part of your brain won't. So it will respond if you're thinking about a previous memory, or it will respond if you are thinking about something that hasn't happened yet. And this is why if you are thinking about, I've got this chronic condition, I worry about ending up in a wheelchair, why do I feel anxious when I worry about that? Well, your feeling part of the brain is responding as if that were happening now. Okay, so there's a couple of structures in the limbic system, the feeling part of the brain, that I just want to draw your attention to, just to help us understand how trauma works in the brain. So we have the amygdala. The amygdala is an almond-shaped structure in the brain, and this is the body's alarm system. This is the fight-flight response. This is the stress system. Okay. Then we have the hippocampus. It's Latin for seahorse, so that's why this is in the shape of a seahorse. But this is generally accepted where your long-term memories are stored. And then we have the thalamus. The thalamus, again, is Latin for inner chamber. This is the relay station. So there is a pathway between the thalamus and the amygdala. There's also a pathway between the thalamus and the prefrontal cortex, and then a pathway back to the hippocampus. So what should happen is, when you have an experience, let's say you might think about, if I asked you, what did you eat for breakfast this morning? Most of you would be able to remember what you ate. Some of you may have had toast or porridge. Now, what would have happened is that experience would have been routed through the thalamus, and that information would have gone to your prefrontal cortex, where it would be given context. Yeah, it would be given the information of time. This happened this morning. So even if your breakfast was the most joyous breakfast you've ever had in your entire life, if you recalled it now, you wouldn't necessarily feel that level of joy. And that's because the memory's been processed and stored in your hippocampus. So you can recall it at will, but it's unlikely to be an intrusive sort of thought. Okay. So what happens is, in a traumatic experience, is that you will see that the pathway to the amygdala is a lot shorter than the pathway to the prefrontal cortex. You also have to understand that the feeling part of your brain will work 40 times more quickly than your thinking part. Yeah? So quite often you will have felt something. People have, lots of people have spider phobias. And they'll say, I know it's silly, Dr. Sherperd, but there's a tiny spider in the room, and I'm just terrified. I know it's silly. Well, actually, they probably felt terrified even before they've recognized that there's a spider in the room. That's how quick the feeling part of the brain works. So what happens is you have an experience. And if that experience involves one of those big emotions that we saw earlier, terror, fear, horror, disgust, shame, embarrassment, humiliation, the amygdala is activated. Now, as soon as the amygdala is activated, it shuts down the pathway to the prefrontal cortex. Why? Because it's thinking, this event was so massive, you don't need to be processing this. This is a threat to your real or your imagined sense of self. We need to deal with this now. Okay? And all your resources are rooted to dealing with that threat, and that could be to fight or to flee. Okay. Okay. So what happens is, these traumatic experiences, the memories of which are never stored in the hippocampus. They're kept outside the main memory network. Why? Because, in a sense, the amygdala, our fight-flight system, is overprotective. It's thinking, this thing was so big, you do not need to be processing this, we need to keep it current. So if anything comes up that's remotely similar to what happened, we can trigger that fight-flight response and you can deal with it straight away. Now this could be, I was mugged outside a wall which was red. Now whenever I go past a red wall, I'm just gonna experience all this fear and this terror. Yeah, it can be as simple as that. So it's a very effective system, but it's not necessarily concerned in your well-being. You're thinking, yes, you're keeping me alive, but I'm just in a permanent state of anxiety. Well, the feeling part of the brain doesn't care. It doesn't care at all. I'm just thinking about your survival. Okay. So what do we need from trauma therapies? So there are so many different trauma therapies, and what we need the trauma therapy to do is we need to revisit the memory in a way where we keep the pathway from the thalamus to the prefrontal cortex open. We need to keep it open so the memory can be processed properly. If it's blocked, all we've done is re-traumatize the client. So every single trauma therapy will work on this premise. Keep that pathway open. It's like having a foot in the memory and a foot in the clinic room. And once we've done that and the memory's been processed, you can think about that traumatic event and not necessarily experiencing that level of distress. So let's just look at that a little bit more closely. So you experience a traumatic event, such as a car crash. Now, in a sense, the car crash isn't the problem. The problem is, you have a memory of that event. Yeah? And it's the memory that's the problem. Yeah? You have a representation in your mind. Yeah, the car crash no longer exists, but actually the memory of that, the representation of that still exists in your brain. And that's causing a problem. Now, there are two components to this memory that are difficult, which is the level of distress and the belief that was created at the time, which is, I'm going to die. Now, remember, the feeling part of the brain doesn't get into past, present, or future. So what we've got is this memory that exists outside our main memory network, which is linked to this information that I'm going to die. Now, logically, I know I didn't die, because I'm still here, but it doesn't matter, because the adaptive processing memory network is not linked up with this, this traumatic memory. So what we need from a trauma therapy is to update that memory, to link it with our adaptive memory network, reduce the distress, and change the belief. I survived. And when we do that, and the trauma therapies are very good at doing that, when we do that, you can think about this traumatic event and not necessarily feel anything. And that's the goal of any trauma therapy. Okay, so some trauma, there's so many different trauma treatments. I'll just talk briefly about some of them that I use. So CBT, I use that a lot in my practice, that's great. However, I find that using CBT, while useful, is, if it's a single incident, that's absolutely fine. If it's more than one incident, it can be quite slow. It's very effective, but it can be quite slow, and they're far faster techniques. And so quite often I draw upon EMDR, eye movement desensitization reprocessing, and EFT, emotional freedom technique. Okay, so for time, I'm going to skip the CBT and go straight to EFT, and then I'll talk about EMDR. So EFT, I don't know if many of you have heard of it, is a tapping therapy. What we're doing is we're tapping acupuncture points around the body, and this links to the body's meridian system. And I find it really, really quite useful. Particularly, I like EFT because I can use it over Skype. Somebody doesn't need to be in the room. With EMDR, I have to do it with somebody in the room. I haven't quite worked out how to do it over Skype. But EFT, I can use it over Skype, or I can use it over the phone. And we do a lot of client consultations over Skype or the phone. So what you're doing is you are thinking about a traumatic event. There are many techniques, but one of them is called the movie technique. So the movie technique doesn't involve necessarily a client having to talk verbally about what happened, but they just have to think. They almost have to mentally rehearse what happened. And I might say to a client, okay, just mentally rehearse what happened from start to finish. And as you go through, just stop the moment you're experiencing any form of distress. So the client says, okay, yeah, I've got some distress. And then we tap. And then we keep tapping until that distress is gone. Until that person can think about that hotspot and no longer feel any sort of emotional distress. And then we move on to the next hotspot. It's really quick. generally we're thinking about going through, sometimes you can, on average, you can do a memory a session. Sometimes you can do 2 memories in a session. But yeah, I find it fun to use. EMDR tend to be seen as the gold standard trauma therapy technique. It is very effective. And so for some of you who don't know what EMDR, it's basically, they don't know why it works, but I'm going to give you my best explanation. It's using bilateral stimulation to aid the processing. Do you remember I was talking about the prefrontal cortex processing memories? So we know that trauma tends to be right hemisphere activity. So if we can bring on the left hemisphere when we're revisiting a traumatic memory, we can aid the processing. And this can be using eye movements from left to right. It can be using audio beats in the left or right ear, or it can be using tapping on either side of the knee. So what people do, they tend to think about the most distressing moment in a traumatic event. Just think about it while they're thinking about the negative belief, which is I almost died, and then they just listen to the beats, or we do the eye movements, and gradually over those current sets, the distress reduces. Okay, right. I've got 2 minutes left before we come to questions. So let me just talk about a couple of case studies. So Melinda, 31-year-old, has EDS hypermobility, lots of those symptoms of, the toxic trio, pain, fatigue, sleep problems. How's it impacting? Days off work, going out less, disturbed sleep. But avoidance was massive in Melinda. She tended not to go out so much. She was worried about being bumped into. And so when we're talking about, she had high levels of anxiety, but what we noticed was actually, part of the approach of a psychologist in terms of pain managing is helping people self-manage. But what was getting in this person's way was that they had these really traumatic memories. And I think for Melinda, she actually met the criteria for PTSD, was she was getting recurrent flashbacks. And so she had 2 particular traumatic memories. So one was the first hip dislocation. I think she was playing sport, she landed badly, the hip came out, she didn't know what had happened, she didn't know she had kind of like EDS hypermobility at the time, nobody knew what was happening, they called an ambulance, the ambulance took about 1 hour and 15 to come. That was really highly distressing for her. We used EMDR. The second one was, once she found out she had EDS hypermobility, she did all the physio, she strengthened all the muscles around her hip. She was quite confident about it. Then she was at the airport, she bumped into a piece of luggage, and she had another hip dislocation. So those were really traumatic. We did EMDR, and I think we'd done the whole thing in 4 sessions. And then she was no longer diagnosed with PTSD. But what was interesting, and this is quite useful for something like EMDR, was that, yes, we spent a good 2.5 sessions on those 2 traumatic memories. And then she said, I still got some anxiety. I've still got anxiety about what happens in the future if this happens again. How am I going to cope? So do you remember the feeling part of the brain doesn't get into time. It doesn't care if it happened in the past, present, or future. So this gave us a window. And what we did was actually, we did, in EMDR, it's called, we installed a future template. So we said, okay, let's take this future memory of the worst thing happening. Your hip dislocates. Your hip dislocates, how are you going to cope? And we literally went through installing how she would cope with this event. And when we finished that probably took about 45 minutes, her anxiety had greatly reduced. She said, yes, there's a possibility of this happening again, but if it does, I will be able to cope with it. And I'm no longer feeling quite so anxious, and I now feel that I have the tools to manage more effectively. So last slide, before we open up for questions. So Pamela, 22 years old, again, EDS hypermobility. And what happened to her, she kind of left home, went to university, and in the first year, she basically collapsed. Had no idea what was going on, and I think she had a cerebral spinal fluid leak, but nobody knew, and she was passed to about 3 or 4 hospitals. It was very distressing for her. So for her, she had 3 traumatic memories. 1 was of the collapsing, 2 was of the diagnosis, and the 3rd was kind of like having back surgery. So here we used EFT, emotional freedom technique with matrix re-imprinting. And so matrix re-imprinting, just because of time, I can't really go into it, but it's really almost imagery rescripting meets EFT. So what you're doing, now it's fantastic to use with males who have a traumatic event and you know it's affecting them, and you're asking them, okay, how disturbing does this memory feel? And they will say, out of 10, probably 2 out of 10. Okay, so they can't quite connect to the emotion. So again, matrix reimprinting is perfect for that. And it's also perfect for people who say, I can't go anywhere near this traumatic memory because it's kind of like, it's 11 plus out of 10. So what you're doing is, the client is not the person in the room, it's actually the person in the room's imagination of their younger self. They're slightly dissociated. So what you're saying is, can you step into the memory? Can you see your younger self experiencing this trauma? And it works absolutely beautifully. And when we're using tapping, what we're getting the person to do is, okay, you stepped in the memory, you can see your younger self. Can you tap on yourself while you imagine tapping on your younger self? And you do that for a few rounds until you've cleared the distress, and then we're left with the negative belief. So at that point, you're saying, okay, so what was the negative belief? What did you learn about yourself that day? And it could be anything from, I almost died, or I was weak. You say, okay, so what would you prefer to think about yourself? Okay, I prefer to think that I was strong, or I'm alive. And then what you're doing is you're using imagery. So we know that the subconscious mind thinks in terms of symbols and pictures. So we're using imagery to think, okay, how can we change this picture to convey this idea that you're strong? Oh, okay. Perhaps I can be standing up, I can be walking freely, my mum's there, my dad's there, I've got a whole support network around me, and I've got, I don't know, Mahatma Gandhi coming and anointing me with something. You can be as magical as you want, it doesn't matter. But what you want to do is create a really positive image that the brain will use instead of going to the traumatic image, okay? Now, of course, you always know logically what happened, but actually, logically is not the problem. The problem is the traumatic memory, which is almost stored in terms of a sensory, visual, emotional format. So that works really beautifully. You can do it over Skype, and with this person, again, this was probably about 4 sessions, and then she was done. She no longer met the criteria for PTSD. Okay. So that's it. That's a little bit about trauma. Thank you for listening, and I'm very happy to answer some questions.
Okay. The first one, I think they mean CBT. They've written DBT, so forgive me if that's something.
DBT.
Oh, yeah. So they've put, do you find that DBT therapy can be helpful for EDS since there can be ongoing traumatic events that can be the same or different versus EMDR that often focuses on one traumatic event? So I don't know if they mean DBT or CBT.
There is a DBT, dialectical behavioural therapy,
okay,
which is a therapy used for people with personality disorder. So, and I don't know so much about that, but I do know that you would not use DBT for trauma. DBT is for managing high levels of arousal, but not for trauma. For trauma, you do need a trauma-focused therapy. What was the question?
So let's
if
say
I assume
it was
it's CBT.
Yeah. Do you find that CBT therapy can be helpful for EDS since there can be ongoing traumatic events that can be the same or different versus EMDR that often focuses on one traumatic event?
Yes, yeah, CBT is really useful. However, I would say CBT is comparable to EMDR and EFT, with the exception that CBT will take longer. So I would always choose EMDR or EFT. Now, in this case, if there are repeated traumas and a person feels able to do this himself, the thing I like about EFT is that it's self-empowering. Once I've told people how to do it, if the trauma is not PTSD and it's not so big, actually clients can do it on themselves, and that's great.
Mm-hmm. Okay. Do you have any knowledge of current studies abroad using propranolol to treat trauma or phobias, and do you think it could be a useful tool in trauma counselling in the future?
Okay, so, okay, that's a difficult one because, in theory, the medication is not necessarily so useful because propranolol is used for anxiety, for managing anxiety. It can bring the levels of arousal down, but when you're working with trauma, sometimes you need to activate the levels of arousal because you need to activate that memory network to update the memory. So sometimes it can get in the way. However, if somebody's coming in and their levels of arousal are so high that they can't even go anywhere near the trauma, then I think something like propranolol can be helpful. But generally, no. If you want to resolve trauma, you have to have a trauma therapy. No medication will resolve trauma.
Do you have experience with ETT, emotional transformation therapy?
No, I've never heard of it.
Okay. They said sometimes perform with light mask. So, a light mask.
I don't know what light mask is.
Okay, no worries. If there are multiple traumatic events close together in time, how do you recommend proceeding? One at a time and in order of how traumatic each one was, or working on all of them at once?
Yeah, this will depend on the client. I would probably get a list of all the traumatic events and generally start with the most distressing, or the client may say, let's start with the first one chronologically. It doesn't matter, I would just follow the client in that. Mm-hmm. Or if there's a similar theme, I might just say, okay, can we work on a picture that encompasses all those events, and let's just work on that. So you could almost kind of like bring them together in one kind of like package and work on that package.
Do we tend to repeat little t trauma in our own behavior?
Oh, definitely. I mean, the thing is about, I mean, I gave the prevalence of PTSD. The thing about little t trauma is that we've all got little t traumas. And they're all affecting us even now. And if we're thinking it's a difficulty and we can start noticing that it's affecting us in a way that's not so helpful, it's getting in the way of our self-management, then I would suggest little t traumas, particularly using something like EFT, we could be doing that by ourselves.
What treatments or therapies do you recommend for patients who suffer with night terrors?
Night terrors, CBT is good. So there's part of CBT which involves imagery rescripting or dream rescripting. So I had a client once, and this worked beautifully with her actually. So she had a diagnosis of borderline personality disorder, fibromyalgia, chronic fatigue. She'd experienced lots of sexual abuse, and she had these recurrent dreams. She said, every night I'm having this dream. And the theme was the same, but the dream changed. But it was always about being persecuted. And so actually, in the session, we just rehearsed some resources that she could use. So in this case, she said, what would really help me? She said, I've got this, I'm in bed at night, and then all these men are trying to break into the house, and I'm just terrified, and I don't know what to do. So we just talked about, okay, what do you need? What's going to be helpful here? And she said, a big dog. A big dog that looks like a wolf. Okay, so we bought this big dolphin, and we just rehearsed, and I got her to do this for homework, just imagining this big dog chasing all these men away. And then she came in the next week, and she said, actually, it's the first time I've been able to sleep for years without having a nightmare. It worked beautifully. I might think about, okay, so is this recurrent dream related to a trauma that we need to address? And I would guess it was. Now, if we can find the trauma, we'll deal with the trauma using EMDR, CBT, or EFT. That's absolutely fine. Now, where we think there's a trauma, but the person can't locate it, or can't identify it, I tend not to go and try and deal with traumas that somebody can't remember. There are therapists that will do it. There's lots of hypnotherapists that will do it, but I just tend to think it's very easy to develop false memories, and it can be very dangerous. So if somebody can't remember a traumatic memory, I'm not going there. I'll start dealing with the traumatic memories they can remember, or just start thinking about how they can manage their symptoms in the present.
Wonderful. Thank you so much, Dr. Sherperd, for coming all this way. Thank you.